Welcome to care planning. This video will cover the basic principles of care planning using a person-centered approach. Here are the contents of the session, including the whats and whys of care planning, how it fits into the assessment process, what main skills you will require to perform effective care planning, some do's and don'ts, and I will go through some examples. Care plans are a clear set of actions that enable the patient and healthcare practitioner to achieve a goal in relation to a specific problem or need. So the fundamental components of a care plan are problem, goal, action. You may find other add-ons in your local documentation, but it's these three that constitute a plan of care. Depending on the context of the care plan, you may use some terms interchangeably. For example, instead of identifying a problem, it may be that the patient needs some help. Or, if you work in rehabilitation, it would be more useful to establish a patient's current ability in the area of concern. The terms goal, aim and objective are also commonly used interchangeably, as is action, plan and interventions. But they mean the same thing. So I've mocked up a care plan with my fake patient Elsie. You may want to pause the video at this point if you would like a pre-read. This care plan is about managing pain. You'll notice that I haven't just written pain in the problem field, I have been more specific. If the problem is specific, it will be easier to compose a goal that is relevant and therefore more likely to work towards solving the problem. If I had just written pain as the problem, I would probably have little choice but to set the goal as to be pain-free, and that won't be useful or meaningful to anyone, least of all Elsie. As for the goal, I've had a discussion with Elsie, and she's in quite a bit of pain and she wants to reduce it so it's more tolerable. We've made the goal measurable using the pain score, so that when we come to review the goal we know whether we've achieved it or not. If Elsie had trouble understanding the 0 to 10 pain scale, I might use your visual aid or using the terms mild, moderate or severe to simplify it. As we have set the goal to be achieved in 4 days, this is when the care plan should be reviewed. This is the time frame. Looking at the actions, I followed through with a specific approach. Elsie has taken some responsibility here also within her capabilities. Note that the actions are relevant to the goal and therefore relevant to the problem. I have acknowledged that wound care is important in managing pain and comfort, but I haven't gone off on a tangent with it. I can write a wound-specific plan for this. Care plans should be smart, personalised, collaborative, concise and legible. A person is more likely to achieve a goal if they have devised it or contributed towards it themselves. Involving the patient in the decision-making process. How can the patient contribute towards his or her care? What actions can the patient be responsible for? What decisions can he or she make? It's important to assess a patient's ability to make decisions themselves. They may have a neurological or psychological impairment and rely on the advocacy of healthcare staff or family. In rare instances, the local authorities can also provide an advocacy service. Achieving a goal should be a collaborative approach. Who else can contribute towards achieving the goal? Care plans should be concise and legible. They should be to the point with no ambiguity. Avoid umbrella terms that are open to a variety of interpretations. Focus can be lost and the goal is less likely to be achieved. Your colleagues should be able to coordinate the care exactly as you and the patient had planned it, and they should be able to read it. Avoid the use of abbreviations. These can be misinterpreted. The same abbreviation can have more than one meaning. For example, FBC could be fluid balance chart or full blood count. Care plans should be smart, specific, to the point. Never assume others will know what you mean. Spell it out for them. Measured. For most goals, you should be able to provide a way of measuring whether you have achieved it or not. We've seen the pain score. You could apply this to someone who is affected by breathing problems. For example, is the chest tightness nil, mild, moderate or severe? Instead, of course, you could use a respiration rate or oxygen level as a measure. If it's wound care, the measure could be the size of the wound or the level of exudate. If it's walking, the measure could be distance. For example, a bed-to-chair transfer with 2 assisting, or walking with a frame without assistance from chair to kitchen. Achievable. Is the goal realistic? Short-term, bite-sized goals form part of a longer-term goal. Achievable goals keep everyone focused and motivated. Relevant. The problem should be in context and relevant to the patient. The goal should be relevant to the problem and the action should be relevant to the goal. Time frame. A realistic time frame that provides a guideline to review. Let's have a re-look at Elsie's plan. Problem. Elsie has pain in her right knee due to recent surgery. Her pain score is currently 8 out of 10 at rest. So it's specific. We have located the pain and the pain level. Goal. Elsie would like to reduce her pain score from 8 out of 10 to 4 out of 10 in 4 days. So I've had a discussion with Elsie and that's what she would like to do. It's more personalised. So actions. Nursing staff will administer paracetamol 4 times a day as prescribed. So I haven't just put medication to be administered as prescribed, I've been more specific. But it's no harm if you do refer to it as medication. Note also that I have identified the role. Nursing staff will do this. Elsie will inform nursing staff if she requires any extra analgesia for breakthrough pain. So we've given some responsibility to Elsie to inform nursing staff when she requires any extra analgesia. Nursing staff will monitor and record Elsie's pain score twice daily. So although we've asked Elsie to inform nursing staff have a duty of care to monitor and make sure Elsie's pain is managed. Elsie has agreed for nursing staff to refer to physiotherapy for assessment and will practice any advice or exercises prescribed by them. So this evidences consent here. Elsie has agreed for nursing staff to refer. And she's also agreed that she'll have a go at any advice or exercises that they suggest. Nursing staff will monitor wound dressing and wound care plan, which we've already discussed. Elsie will elevate her leg on a high footstool or take bed rest in the afternoon. So we've actually differentiated between footstools as well, because as you may have seen, some of the footstools are very low and don't really do much at all. Elsie will inform healthcare staff of any concerns or suggestions as necessary. So the care plan actually encourages Elsie to make any suggestions to staff that she can think of. It's collaborative. In practice, of course, there would be a section to write the patient's identifiable information, but we haven't got this on this example here. And at the bottom, all plan discussed and agreed with Elsie, and we've got the signature from the practitioner and the signature from Elsie, and we've dated it. Also note how many Elsies we've got in there. But I've not just written Elsie just for the sake of writing Elsie. It's incorporated into the plan. It's definitely Elsie's care plan. Care plans help to focus care, but you don't need a care plan for every aspect of the patient's life. Identify what is the focus right now, and what do we anticipate the focus to be in the future. Care plans are good for continuity, for monitoring progress, for communication and timely referrals. This also helps when transferring care to another department, care agency or reablement. They can see clearly what is required. Care plans are also a legal document, so ensuring that they are accurate and up to date is of paramount importance. So here is the full assessment process. Assess, set the goals, plan the care, initiate the plan, review and reflect, and evaluate. We'll start off with these first three. Assess. This is where you put on your detective hat and collect your objective data, facts, and subjective data, opinions and feelings. What information do you have to hand now, and what information will you need to acquire? Where do you start? Airway, breathing, circulation, disability and exposure is always a good place. Collecting objective data would come from doctor's assessments, blood pressure, temperature, pulse, respiration rate, oxygen levels and blood samples, to name a few. Also, past medical history and allergies. Neurological observations are at risk of being interpreted subjectively, so you need to ensure that your assessments are accurate and as objective as possible. To gain a richer and wider understanding of where the problems lie and how to prioritise them, it's important to listen to the patient's narrative. What is their understanding of the problem and how does it affect them? This helps put things into context. These type of assessments do not need to be done in one go. Set a time frame for the conversation. Explain to the patient that you are dedicated, for example 20 minutes, to gain an initial understanding of the problem, and then that you will return later to discuss the rest. We'll cover core skills later in the video. Now, I fully appreciate that sometimes you do just have to get on with the actions if it's urgent. For critical problems requiring urgent intervention, it's a case of gaining consent and acting in the patient's best interest. When the critical moment has passed, write the plan. Find out what's important to the person. What does the person want to achieve? What does the assessor observe as an achievable goal? Work together to devise the goal. The patient is the expert in how the problem affects them. If it's a long-term condition, such as diabetes or heart failure, for example, they might already have some ongoing actions and coping strategies. You, as the expert assessor, are the objective professional who brings to the table clinical expertise, experience and skills to help enable the person to formulate a goal that is achievable and works. Plan care. This is your set of instructions and interventions that help achieve the goal. These are the main aspects of life. We'll focus on nutrition for our next care plan. Barbara says that she has lost 2 stone, 12 kilos in weight over the past 6 months. She thinks it may be due to issues with nausea. So we can see that the root cause of the problem at this point of the assessment appears to be nausea, the cause of her weight loss. And we've used the patient's narrative to describe it. We've paraphrased. But you can see potentially the situation could be clinically quite serious. Goal. Barbara would like to regain some lost weight and enjoy her food again. Aim to gain 3 kilos in 3 weeks. So the goal is personalised. We've identified and acknowledged what Barbara would like to happen for her well-being and for her comfort. And we've put the realistic, appears to be realistic at this point, goal of to gain some weight in the next 3 weeks. But the potential seriousness of the problem is reflected in the actions. Refer to doctors for assessment and investigation. So the doctors would probably be on the case by now. Complete malnutrition risk tool and refer to the dietitian, and that's to be reviewed weekly. So even though our care plan has a time frame of 3 weeks when we would expect to review the care plan, because we need to do these mini assessments and mini reviews in the meantime, we have stipulated that in the actions. Commence food diary. Barbara will complete this, review weekly. So we've given some ownership to Barbara within her capabilities. Nursing staff will record fluid intake and output, monitor and intervene with IV fluids if needed as per doctor's prescription, and that needs to be reviewed daily, so the nursing staff are keeping a close eye on Barbara. Obtain blood sample and send for full blood values. Monitor vital signs 4 times a day, measure weight in kilos daily and record. Monitor for signs and symptoms of refeeding syndrome. Encourage Barbara with oral fluids. So I'm not telling her what to do, I'm encouraging her, I'm enabling her, I'm motivating her. Administer antiemetics if required, as prescribed. And Barbara's daughter Eve will bring in some home-cooked food as Barbara prefers. So we're working more collaboratively with Barbara and her daughter we're acknowledging Barbara's preferences and choices. But I've also put in accordance with dietitian advice, because the dietitian may have some specialist advice, taking into consideration her risk of refeeding syndrome. Let's look at mobility. Bill is unable to walk without staff assistance due to loss of confidence following a recent fall. He usually walks unassisted with a stick. So this problem is opposed to writing something like loss of independence, or another common one is off legs. The word independence does not really tell us a lot. There is sometimes a general perception that mobilizing independently means to walk unaided without assistance. But I'm sure you'll agree that independence is in the eye of the beholder. In this case, Bill perceives his independence to walk unassisted with a stick, because this is what he did day to day without problems prior to his fall. Bill would like to regain his confidence and walk the length of the ward without staff assistance using his stick in 2 weeks. So it's smart, we've got a time frame, it's measurable, being the distance, and it's personalised. And we know this, it's evident, because the sentence starts, Bill would like to. And here are our actions. Collaborative approach here. Ownership of Bill to let healthcare staff know when he needs assistance. To initiate the plan is the doing part of the plan. It's putting the plan into motion. To review the care plan, you and the patient are asking, was the goal achieved, partially achieved, or not achieved? If the goal was achieved, then well done. The patient can progress to a new goal. If the goal was partially or not achieved, reflect with the patient, physician, and your colleagues, and those others that you have been collaborating with. Discuss what worked well and what not so well, and explore why if it's not obvious. Now you can either progress to set a new goal or amend the current plan. If you are updating the care plan, be sure to date and sign the amendment and score a single line through the part that is no longer required. Document any discussions in the evaluation. Document any variant actions or deviations to the plan, problems, update progress, omissions and decisions, referrals, conversations and communications. It's important to identify barriers to communication to give you and the patient the best opportunity to formulate a plan that works. Ensure the patient can see you and can hear you and avoid making assumptions. This is easy to do, particularly if you're short of time. I've done it in the past, but it's so rewarding when a patient engages with you because they can see that you have taken the time and made the effort to truly communicate with them. And ensure that they have the means to communicate back to you. And ask the patient their preferred name. Be self-aware. Adjust your voice tone and volume, your proximity to the patient, appropriate use of terms and language, and being sensitive to delicate discussions. Try where possible to be objective when listening to and processing the information the patient gives you. This will help you enable the patient to make informed decisions about their care. It will also help you to be impartial and non-judgmental. When these discussions take place, it does help to be assertive. You want to help the patient in the most holistic way possible, however the reality is you will have competing demands. Ensure the patient is aware of this without causing them to feel less important than the other patients, because they're not. Before a meaningful discussion takes place, ensure you have given yourself time to do it. For example, you haven't left an intravenous infusion that's about to finish and you have to rush off. Why not delegate this to one of your colleagues to take care of? Then, inform the patient how long you intend to spend with them on this occasion. For example, 30 minutes might be the time. This facilitates you to say at around the 25-minute mark that you have about 5 minutes remaining and keep focusing the patient back to the important points. However, it wouldn't be appropriate to do this if the patient was in distress. Comfort them and reassure them instead. The patient may be so stressed that they don't know where to start themselves, so a bit of assertive direction and guidance may be just what they need. Summarise important points and write them down, because this could help you and the patient identify problems and potential goals. Provide reassurance to the patient and ensure that they and their loved ones are realistic about expectations and have contributed to that conversation. Ensure that privacy, dignity and confidentiality is maintained and that staff are proactive in ensuring equality in practice. Do. Involve the patient in the decision-making process as much as possible and appropriate. You can evidence this in your care plans by referring to the patient by their preferred name. Start the goal with Eric would like to, or Eric needs support with, rather than to be or to be able to. This switches the ownership of the care plan from the nurse to the patient. Don't. Don't write a care plan just for the sake of it. Make it count. Don't write a care plan for every problem and every need. Write the ones that are relevant and proportionate to the current priorities. Don't incorporate more than one problem and goal within the same care plan. One problem equals one goal. Don't mix them up. Don't write a care plan that isn't smart or personalised. For example, problem, mobility. So here I have used a very generalised term. Mobility could refer to anything: arms, legs, fingers, toes, head, eyes, any part of the body that moves. Goal, to be independently mobile. That's two generalised terms. It doesn't really tell us a lot. How will we know when we have achieved that goal? Actions. Lots of abbreviated terms. Physio, OBS, P-care. Is that pressure area care or personal care? Here's another one. Problem. Mobility. Requires a physio referral. So here we have a problem and an action in the same box. It's really important to differentiate between the problem, the goal, and the action. Goal. To be independently mobile and be independent with daily tasks. So here there are two goals in the same box. And apart from lacking in smartness, it could potentially yield a lot of confusing actions. Thank you for listening. I hope you have found this video useful.